are. So, yes, indeed.
You always have lots going on.
I am never bored, Linda. You're absolutely correct. There's
Ever.
Well, there's always, you come to the end of the day and you realize that, that there's certain things that are really important in life, and it happens to be the kids that we're taking care of. And I know Deanne will love this, but I was like, I went out, years ago when I started a lot of my research, and I was very academic and a lot less, advocacy focused, but much more medicine and research focused than that. I was one of the founding members of a group in New Zealand to look at creating effective ways to deal with child sex abuse and sexual assault and domestic violence in the population. So one of the women that helped me start this, that I worked with and spent a lot of time with down there, was in town, and I drove to Palm Springs. That's not the point, but I decided not to stay over. I came back late at night on Sunday night, and I was in the car, and it reminded me of being a little kid in the back seat of my dad's car driving all over California in all time hours of the night, getting home really late, but knowing the whole time that I was safe. That you're safe in the car. And I was reminded that you're going to get home and somebody's going to carry you into the house and you're going to be safe, right? And that is, remember those feelings? I'm sure you do. But last night I was at the clinic late and it's getting dark, and the social worker is bringing in this cute little guy with a red afro, and he in the back of the car, and the whole thing kind of washed over me that this little kid had absolutely no idea where he was going, right? Unlike me, he's not going home, right? He's going someplace he doesn't know. And that's got to be scary, right? So anyway, I see that Kim's on, so all small talk has to stop. Right?
Appreciate you sharing that, Astrid.
Me too. That's the bottom line of what we all want, is for children to be safe. Thank you, Astrid. You remind us of our real mission in life. Thank you.
Yeah, it was just amazing. I sat there, watched this kid, and I could feel myself becoming verklempt, about like, where's this little guy going, and where does he think he's going, right? What do you think is going to be at the end of the line for him? And it was just a moment standing there, and I thought, what we really are all about is how do we get the kids to know that when they're in the back of that car, they're going someplace safe, right?
Yes. Thank you.
Anyway, good.
And all commissioners are present, excluding Dr. Robert Byrd, and still waiting on him, but we do have quorum and we can begin when you're ready, Astrid.
Good. So it's my role to call us to order, I believe, first and foremost, right? And I'm going to let you do that, Linda.
The meeting is called to order at 1:30. And before we begin, I'm going to be covering some ground rules. And as you are aware, under AB 361, members of the First 5LA Board of Commissioners and the public members can participate in this meeting via teleconference during declared emergencies through January 1st, 2024. Now, in the interest of maintaining appropriate social distancing, members of the public may observe this meeting telephonically or otherwise electronically as posted on our website and this agenda. And before we begin, I do want to cover the two ways that you can submit public comments. The first way is written public comments must be submitted in advance of the meeting via email to myself, which is lvo@first5la.org by 1:30 p.m. the day of the meeting, in order for them to be read aloud during the meeting. And as a reminder, public comments emailed should indicate the item number the comment corresponds with. Any public comments received after 1:30 p.m. via email will become a part of public records. Now, during the meeting, public members can use the Q&A chat box function to express an interest in speaking to an item. And it is important that these requests to speak be submitted via the Q&A chat box before the item being commented on is presented. When submitting requests to speak, public members are asked to only provide his or her name and the item number the comment corresponds with. All public comments received during the meeting via the Q&A chat box will be addressed in the order they are received. And when public members do hear their name being called, you will be given the ability to speak during the meeting. Now, if we don't hear you begin your comment upon your name being called twice, we will move on to the next public comment. 2 minutes are allotted for each comment, and once the 2 minutes have passed, we will move on to the next public comment. And finally, just a reminder to all, to minimize background disruptions, all board members and staff should place their lines on mute until called upon to speak. And to minimize multiple people speaking at the same time, and to ensure for a coherent dialogue, board members can use the hand raise or chat box function to express an interest in speaking. And then I'll coordinate with Committee Chair Hager in terms of who will be called in the order that they are received. And with that, I'm going to hand this over back to our Honorable Committee Chair, Astrid Hager.
I'm working on the honorable part, but thank you for that. Item number 2 is for to review the Program and Planning Committee transcript from April 21st, which unless all of you are better humans and more honorable than I am, you've all done that. I think that's for information only. And I believe we can move on to item 3. Please tell me if I can't do that. Because I'm really interested in some of the reports today, tremendously interested in them actually. And our first item 3 for information is on home visiting and system building efforts and sustainability opportunities, all of which we are totally invested in. And we have a variety of presenters, and I will let them go down the line. I can call them. Are they starting in the order that's listed here? Diana, are you going first? All right, so we'll cut to you and then let you hand it off to Anna and Deborah and Charlene. All right.
And Deanna, if I may, before we move on to item 3, for the record, confirming that there are no public records for item 2.
Oh, yes. Sorry about that. All right. Can we go on with Diana then?
Yes, we can. Thank you, Commissioner Hager. So good afternoon, all commissioners, staff, and guests. We're happy to present an update today on our home visiting, system building, and sustainability efforts. Anna will be sharing her screen. I am joined today by Anna Petir, Senior Program Officer from our Children and Family Center Support Unit, Dr. Deborah Allen, Deputy Director for Health Promotion at Department of Public Health, and Charlene Gonzalez, Director at Los Angeles Best Babies Network, or LABBN. And I will call out, we did move up one slide out of order, but the information you have on all the slides remains the same. So the next slide. We have provided various updates to everyone in the past few years about home visiting efforts around systems building, policy updates, compensation, retention, evaluation. So the most recent update was last year in May of 2021. And since then, there has been significant and foundational systems building work that has happened. So we're excited to share our goals for today is really to provide key updates on those home visiting system building efforts, particularly around leadership and data and on sustainability strategies. And we have reserved time at the end for discussion and questions. So the next slide shows the vision for home visiting in the county. So as a reminder, our home visiting work is part of First 5LA's strategic priority of strengthening public and community systems with the goal of providing leadership to support the development and expansion of a universal system of voluntary home visiting that really builds upon existing infrastructure. So this goal aligns with the shared vision for home visiting in the county. This vision comes from the 2018 Home Visiting Action Plan, which was a result of Supervisor Kuehl's board action back in 2016. There have been a number of key Board of Supervisor motions since 2016, but this first motion really spurred collective action with Department of Public Health as the lead and in partnership with First 5LA and other county departments, including health services, mental health, DCFS, and others, to really bring a more focused support and effort to creating a coordinated and integrated home visiting system. The next slide, you'll see one of the results, as I mentioned, of that 2016 board motion was the Home Visiting Action Plan. So this action plan has really been a foundational document guiding the work since 2018, and it reflects the blueprint for a transformation and a core framework to guide the coordination and collaboration efforts between key partners across the county. The goal has been to follow this action plan with the development of a more detailed implementation plans for the county where partners and departments can come together to execute the plan where home visiting can play a crucial role as part of a comprehensive set of strategies that are designed to maximize outcomes for young children and their families. So this last year represents a continuation of this work with an inclusive planning process and a focus on building out the infrastructure needed to implement that system-wide approach. The next plan really lists the system partners that have been involved with the shared commitment to leadership and system level activities. The approach has been based upon a systems building framework that has helped to organize the work and address the complexity of having multiple funders and stakeholders involved. So as you can see here, all of the key system partners involved, those include those providing direct funding and administering funding, particularly for 5LA and DPH, LABBN, which provides key system infrastructure support, the LA County Perinatal and Early Childhood Home Visiting Consortium, otherwise known as the consortium, the Collaborative Leadership Council, which I will explain further in the next slide, and then home visiting providers and families. We know there are some decisions that are clearly held at the state level, such as funding allocations or eligibility requirements. But all of these partners are working together to identify local system successes, to elevate challenges, and to use data to inform and influence decision-making and development of recommendations with that shared goal of improving the quality and sustainability of our local home visiting system in the county. One foundational and significant advance for implementing the action plan has been in the areas of governance and leadership. So first I will highlight the development of the Collaborative Leadership Council, or the CLC. So the CLC on the next slide was created in 2019 with facilitation support from the Office of Child Protection. Purpose of the CLC is to perform ongoing monitoring, adjustment, coordination, and advocacy for home visiting, and to identify opportunities to deepen the connections of the work between home visiting and other prevention and family strengthening work underway in the county. Members of the CLC are intended to serve as a bridge between executive county leadership, home visiting funders, experts, and providers. And eventually the goal is to also build the infrastructure to include home visiting client voice. So the board motion from 2016 identified the Department of Public Health as the lead department to collaborate with key system partners, and they are responsible for chairing the CLC. So with that, I'm going to pass it to Dr. Allen to speak to DPH's role across the key foundational elements of the home visiting system efforts.
Thanks so much. Thanks so much, Diana. And I just have to take a second to thank First 5 LA for its partnership in this, the value of having a thought partner so consistently throughout our thinking has really been overwhelming. So where we see the system building making sort of posing challenges for us that we're working hard to meet are first around governance. And Diana talked about that, about the idea of starting from a shared leadership philosophy and really thinking about governance at several levels, at the management team, which will be us, First 5 LA and LABBN, with the Collaborative Leadership Council as our advisor around policy that is advising the management team, and then with the consortium, really thinking about what happens at the implementation level, at the field level, working with families. Second really critical element in building a home visiting system is assuring we have the data to understand who we do and who we do not serve, where the gaps are, where the opportunities for improvement are. And we've been quite happy to have received a grant from the county's Productivity Investment Fund that will allow us to form an integrated home visiting data system. We're calling it HVIP, for Home Visiting Integration Project. And we have just today signed our contract with LABBN, to whom the funding will go to lead this process. They will be hiring a systems development consultant to do the technical part of the work, but their job will really be bringing the entire system, including our providers, along in creating a data system. They'll be creating what we call a data lake, into which all of the providers will send their billing, their data, and it will then be able, through an automated process, to produce all the reports they need for different funders and for different models of care, while at the same time allowing us to look very holistically at the system rather than breaking it down by model or funder. So we're very excited about that and expect that we will actually come up with a plan within a year and then begin to work on implementation. The third area that's really critical to both sustainability and growth, and in particular growth in terms of our capacity to reach parts of the population where we feel the system has not been fully effective. And those include both Black women, who we know are at higher risk for adverse birth outcomes, and segments of the population that face particular social challenges, including homeless women, including women affected by mental illness or substance abuse, including women who are leaving the prison system. The models that we have allowed us less ability to reach those populations, and new sources of funding are really critical that allow for greater flexibility, are really critical to our ability to do that. We've been invited by the Hilton Foundation to submit a grant, which has now gone in. We are now waiting to hear, and it will allow us to do two things that for which otherwise funding is lacking. The first is to create a new position at DPH. I mean, our history is as a home visiting provider. The funding will allow us to create a new position whose job will really be to look at the system as a whole. And secondly, to create a unified billing system that will, we hope, allow us to take advantage of funders, including Medi-Cal and including the Families First Prevention Services Act, FFPSA, that will allow for greater flexibility in the models that we fund. So this is really a critical step, we believe, for us, and a tremendous opportunity to build a system that has much greater capacity and flexibility. This focus on financing comes out of the work of a consultant that helped us over the last year, and that we'll be talking about more in this presentation. But I really wanted to highlight these three areas as critical for building a system rather than the patchwork that currently exists of sort of discrete standalone models. Thanks very much.
Thanks, Dr. Allen, and I'll go ahead and step in for the next slide. Good afternoon, commissioners. Thank you for the opportunity to provide an update regarding the infrastructure support that LA Best Babies Networks provides the home visiting sites. Given LABVN's responsibilities as the oversight entity for the first 5 LA and county funded home visiting models, we are in a very unique opportunity because we just have so much access with all the hospitals and community-based organizations. Where we started off 10 years ago as the oversight entity has really changed. When we started off 10 years ago, it was all about how do we start home visiting in the county? It was all about training, standardizing protocols, getting people to workforce expansion, making sure we have our ducks in a row in terms of consents and database and all sorts of things like that. But in the last 5 years, we've really shifted because the sites are now full-fledged. They've been doing the work for a while. They are the experts for their own work. And our infrastructure support has really shifted in being a county-wide system building process. In that, I mean, it's moved more towards data-driven decisions, which I'll talk about in just a moment. We've been really working on workforce expansion. We've been providing support with FFPSA work. We've been doing connections work with other academic institutions like USC to do deeper data level analysis. What we're also finding ourselves is the type of technical assistance, the training, the data work that we're doing is not for a newborn program. We've really gotten into the weeds of things and are trying to perfect and heighten the quality of what we're trying to do, but also the outputs. So we look at it in two ways. What are we doing with the families, continuing that ongoing continuing education process, addressing needs as they come in real time, but we're also trying to build the county and advocate for change based off of what we're seeing in our programs. So you'll notice a lot of what we do is about identifying, integrating, and evaluating. And the beauty of the way we're set up is we really can address things in real time. Given the support that we have from First 5 program officers and the implementation team at the county, when something is identified, we can move fairly quickly to provide that infrastructure support that the site or the larger network needs. The other piece of this is, I think it's quite wonderful, is we have the sites that may be funded by multiple funding sources like the county and First 5, but there's standardization. And that's the beauty of this work as well, is that we've been able to create standardization in what they're doing and their expectations, their deliverables, their data outcomes. The simplest things of when we say exclusive breastfeeding, is it the same definition for all funders? This has been a big piece of the CQI and data-driven decision work as well. Next slide, please. Because LABBN is the oversight, it's also created us an opportunities to have really close relationships, as I mentioned before. We're able to do ongoing continuous quality improvements directly with sites and on a network level. The current Stronger Families database is a web-based system. It provides opportunities for case management. It has an inter-network referral capacity. It allows the providers across the system to speak with one another. The best part is, and as being a data geek and the co-lead for the data work group on the consortium, is that it's connected to Tableau. So whatever you put in, you can absolutely pull out into a dashboard. So that's created an immense opportunity for us to be able to, whoever's inputting data into that system, to be able to pull it back out. And where we're sitting, LABBN can see all that information across the models, across the sites, and across the funding sources. We're able to take that information back. We bring it back to the funders. We bring it back to the consortium. We really bring it back to anyone who will ask us for information in an aggregate, de-identified format. But what this allows us is the opportunity to advocate. It actually shows a better picture of what the ripple effect impact is of home visiting in this county. What used to be just siloed in some sense, just to maybe First Five, now with county using the same database system, we're able to show a bigger impact of what exactly are we doing when we talk about the 25,000 families that HFA, Welcome Baby, and Parents as Teachers are seeing on a yearly basis. We also have the ability to make sure that all the sites are meeting or at least following model fidelity. I've always looked at ourselves kind of like the middle group between the funder and the grantee. We're the group that comes in and just makes sure that the grantee has everything they need at their fingertips to integrate the program with model to their fidelity, both to the national office, but to their funder as well. That model fidelity is also incredibly important because it's tied to program outcomes, evaluations, and so on. But the last point right there, feedback loop, is I think one of the things that we've also done really uniquely is we bring everyone together, regardless of funding source, regardless of model, and regardless of a pandemic. We've just had to switch to a virtual model. And on a monthly basis, we're able to bring all managers, supervisors together. On a quarterly basis, we bring the peer roles together, continuing education. But what this creates is an ongoing opportunity for conversation, things that really deep dive into the themes that we're seeing, the topics, the trends, and again, and being able to real-time address them. Next slide, please. My last slide is focusing on the consortium. Hopefully everyone here at some point has heard of the consortium, but the consortium is funded by First Five and the LA Partnership for Early Childhood Investment. It sits within LA Best Babies Network and the Policy Committee. And it is a network focused on coordinating, measuring, and advocating for quality home visiting programs in LA. As it currently sits, the consortium has multiple work groups focused on African-American home visiting engagement, father engagement, best practices, data, referrals, advocacy, and these work groups meet on a monthly basis to push forward an action plan. It's an opportunity to bring together 60+ member organizations, including representatives from the models themselves, county agencies, funders, insurance programs, nonprofits, advocacy organizations, foundations, and philanthropy. It is that space that every quarter we get together and we talk about the larger issues and update folks of the work that is going on. It also creates camaraderie, and it's that coalition building that, quite frankly, we haven't been able to find another model like this in the US as large as ours. We've been getting more and more interest of how is LA County doing this? What is this concept of an oversight? What is this concept of a consortium, and how do you do it on such a large scale? And I think part of that is just the way that we've been able to connect. We have a common mission and vision, and just really tapping into the expertise of the multiple groups involved to push this work forward. And again, it's all about systems building and infrastructure support. And it's that ability to address things in real time. So with that, I'll also pass it on to Anna for her next slide. Thank you.
Thank you, Charlene, and good afternoon, commissioners, colleagues, and guests. You've heard about the incredible home visiting system that has been built in LA County and some key elements for looking to the future. I will now briefly speak to how we're exploring sustaining this system to ensure that families can continue to benefit from these services, recognizing that systems building and sustainability are inextricably linked. On this slide, you can see a working version of First 5 LA's vision for sustainability, which is to create a spectrum of equitable social services available to pregnant and parenting people and their children, supported by sufficient and sustainable funding. We plan to continue refining this in partnership with LABBN, DPH, and other partners such as those referenced earlier by Deanna and Charlene. This can provide a broad framing for what we are hoping to achieve through sustainability. On this slide, I dive into further depth on our strategies for achieving this vision. We have narrowed it to 3. So to diversify home visiting funding sources in order to sustain programs as First 5 LA revenue declines, to create longer term financing mechanisms to ensure stability for providers and therefore stability for families. And third, which you have been hearing about, to develop the necessary system infrastructure to support a quality system with multiple funding streams. Finally, I'm excited to speak in a bit of greater specificity around the emerging opportunities we are exploring to maximize potential funding streams for home visiting. We are fortunate to have access to a number of wonderful resources to help us determine the best strategies for moving forward. For example, and which Dr. Allen alluded to, we had an opportunity through a grant from the Heising-Simons Foundation to engage in a fiscal mapping exercise with a national expert consultant in home visiting financing, Kay Johnson. Kay led a group of home visiting and financing experts in a process to build a shared understanding of how to maximize potential funding streams for home visiting in LA County, which resulted in a report in March of this year that includes a set of recommendations. We are still working to think through and prioritize Kay's recommendations, but some of them are already underway and we plan to continue exploring them. For example, we continue to work with DCFS and partners across the county on the implementation of the Family First Prevention Services Act, or FFPSA, which includes potential reimbursement for 3 of the home visiting models that are currently implemented in LA County. Medi-Cal, California's Medicaid program, is another federal opportunity that holds potential for home visiting, particularly at this point in time, as the state is rolling out multiple transformational initiatives in Medi-Cal. Given that the majority of pregnant people and children under 5 is enrolled in managed care, working with Medi-Cal managed care plans is an important strategy for exploring these opportunities. Finally, Dr. Allen mentioned the centralized billing system for home visiting, which was a recommendation from Kay based on her work in other jurisdictions and providing the ability to maximize these reimbursement-based funding streams. We look forward to continuing to explore and prioritize Kay's recommendations. Now I will hand it back to Deanna for our Q&A and discussion. Thank you.
Thank you, Anna. So I hope you can see there has been significant progress in building out the infrastructure to lead efforts for this more coordinated and effective system that is responsive to community needs and it's easier to access and navigate. We're really excited to be advancing in the areas of system leadership, data, and sustainability. And we're enthusiastic about the ongoing level of collaboration and partnership between partners, as you can see here, by the examples given by Dr. Allen and Charlene, and the emerging opportunities to engage other system leaders and county departments as part of sustainability strategies, as highlighted by Anna. So at this time, we wanted to open it up for discussion and questions about the system building and sustainability efforts or any other feedback that you may have. Thank you very much.
Anna, this is Deanne. I have a question. First of all, thank you so much for connecting with us and with Dr. Durfee and with ICANN. We have a ways to go, but at least we're on the road. I have my usual question about how we actually are evaluating outcomes. We're talking about better outcomes, and I'm not sure what those are, how we're measuring them. That would be my first question. Do you want me to ask the second one?
Yeah, we can pause there, and maybe if I can invite Charlene to maybe share some thoughts about the partnership we are doing between LABBN and USC to assess some of that data.
Absolutely. I'll start off there, and then I've got a couple of more examples as well. So what we actually did with the support of First 5 is we did a complete data dump from the Stronger Families database that has data all the way from the beginning of when we started using it. What this created was an opportunity we wanted to dive deeper and see if there was anything that we could predict, like predictive outcomes, based off of the hospital assessment, the Bridges assessment tool. So that's actually something that's ongoing. We're utilizing with USC's partnerships, we're able to use their PhD students in epidemiology and statistics and utilize their resources to dive deeper into that data. So that is forthcoming. The other space of what we do is ongoing because we have access to the data is we look at the outcomes year to year and see how it's changed. And that was incredibly important, especially during COVID. We saw increases in some area, decreases in others. But what we do see is when we ask folks to bring the data into the consortium, so the data work group, is that we do see that consistently, if the program is with that outcome, we are doing better than county statistics compared to families who may not be in home visiting. That is true for things such as screening rates for depression, anxiety. That is true for screening rates for ages, stages questionnaire, better outcomes in terms of immunization, following through with prenatal visits, postpartum visits, less domestic violence, less substance abuse. But I will also say that we assume, even though it's under 1%, we assume that is an underestimate just based off of what is told to us, let alone our drop-off rate or loss to follow-up rate. What we also see is we are also able to tell things such as dental screenings. We're able to also look at breastfeeding patterns. We're able to even break it down by Best Start community and see the differences that perhaps we see in SPA 1 compared to SPA 8. And then what we also have done is we look at to see if there are areas, dosage basically. So is there a difference of outcomes depending on how long someone gets the program? So especially for our folks in HFA and PAT who potentially could get the program for 3 to 5 years, what are the differences compared to something like Welcome Baby that's light touch? So we are seeing positive results. And I think through the data work group, and I'm happy to share the consortium website as well in the chat box. But there's multiple reports starting from 2015-16 fiscal year that show where we were back then. And then it does comparative across various home visiting models, not just Welcome Baby, HFA, and PAT. It actually includes some early Head Start. It includes some NFP data. It includes Healthy Start. And then unfortunately, next year, we're also going to be including family preservation and PFF as well to just keep expanding.
That was extremely helpful. Thank you so much. When you mentioned domestic violence, are you including child abuse?
We are.
Family violence then?
Yes. And I know First 5 program officers also have their separate tracking system that they require their grantees to follow. And that's as related to making calls or like what is substantiated into a call. Or not a call, what's substantiated into an actual case, and so on. So we do track that.
I would love to have that data if it's available. Thank you. I have another specific question. Is there a connection between the newborn risk assessment mandate and the referrals for home visitation? I guess I'm really asking what the criteria for providing the home visitation is for newborn, for families with newborns, but there's a system for identifying risk with newborns, and that actually results in a referral to DCFS. But it would seem that there should be a connection between whoever's making that assessment and whoever is assessing for home visitation. Do you know? I mean, is that something we can explore, because there is a growing number of newborns being referred at risk. It's a very large number. So it's
There is some work underway with the Plan of Safe Care work group, and I know maybe perhaps Anna can speak to that. And that's one possible way where we're trying to link referrals to home visiting as part of identifying families at risk. And Anna, if you want to share a few words.
Sure, thank you. So the Office for Child Protection is leading a county work group to establish a plans of safe care protocol, which some of you may be familiar with. And so essentially this is to identify children, newborns who are substance affected, and to determine whether they should have a plan of safe care in place or whether they should be referred to DCFS. And one of the referral options for those families is home visiting. So that is still underway. And Commissioner Tilton, to your question about the newborn risk assessment, that group has been looking at what the kind of assessment would be to determine which path the hospital worker takes in those situations, and has been looking at, actually looked at our Welcome Baby Bridges screening tool as an example, and has looked at the newborn risk assessment as well. And they are designing kind of a new, based on those other assessment tools, a new sort of assessment tool. And I'd be happy to share that with you or provide any additional information.
That I would really love to have that. And you've pointed, you made a very clear point just now. There's the newborn risk assessment, and there's the still the plan, the forward plan for reducing risk and improving family functioning. And I think that there's like 1,000 newborns that are referred at risk to DCFS, and it isn't just substance abuse. As you know, the newborn risk assessment can't just be a positive talks. It has to include other information. So I'm really glad this is being addressed jointly, and I really would be interested in being connected to how it goes forward. Thank you so much, Anna.
Absolutely, thank you.
And Deborah Allen, and then Romalis Taylor.
Well, I just wanted to comment on both of those questions. I mean, first, in terms of evaluation, I think in the expanded vision that we're promoting for home visiting, the first question would be, do we succeed in increasing our representation of populations that are now underrepresented in the system? And then I think we have to think about, how do we do population-based measurement, given that the access to a comparison group is a more complex question. But I do think we have to think about whether, if we're thinking about this as a countywide system, does it have countywide impact beyond the impact it may have for individual children? So it's very much on our minds, but it's a future question. And in terms of referral for home visiting, I did have to give a plug for our newly instituted Help Me Grow program, that it not primarily focused on newborns, but we really do intend to do a lot of outreach to pediatric providers, and expect that they will be a primary source of referrals to Help Me Grow, which can then refer to a whole host of programs, including home visiting as appropriate. But we see that as a really critical sort of bridge in the system to get families to the resources they need. And it is up and running just as of now.
That's very exciting. And so there's just a lot of investment I have in this issue, because I do believe it does profoundly impact not only the health and well-being, but the safety of children. And it is clearly something that that is morphing into an entity beyond just child abuse, but at the core of all of this, the very survival of children, of newborns, is a point to consider, because this is a highly vulnerable stage of life, and you know that. So Deborah, I know that we had connected with you about increasing the home visiting for at-risk families, and also expanding the hospitals, the number of hospitals who are participating. So I'm wondering if we have, how we're doing with expanding into, well, more hospitals, county hospitals, and also addressing those high-risk parents that were so thoroughly and articulately identified in your board letter year before last, with, for example, the jail population, the newborns of women incarcerated. Just one little example of that. Go ahead.
Well, we are very happy that we have a current grant that allows us to do doula care in the jails. So quite excited about that.
Wow.
In terms of expansion of the Welcome Baby model is the model that's involved in the hospitals, and that's run by First Five, who probably want to comment on it. It's their baby, but the possibility of expanding Welcome Baby was really a key recommendation in this report we got from our financing consultant, who envisioned going to really looking to Medi-Cal as the basis for funding expanded Welcome Baby, which makes sense given its hospital base. So I don't know if Diana or Anna wants to add to that, but the notion of having an expanded system with capacity to have a direct connection to more mothers at birth is really grounded in expansion of Welcome Baby.
And currently, I would just add, I mean, given where First 5 LA's revenue is, we're definitely looking at our sustainability strategies to maintain or assess our current infrastructure. So we're not currently looking at expanding, but looking at how do we really bring in other funding pieces. So our work with managed care has been really important for that. And some of the recommendations that Kate Johnson's report called out, such as the CHWs, will really kind of help support our thinking as we look at how do we engage other partners and sustain the current infrastructure. And we're also looking to, even as part of the work with ICANN, looking at how do we create maybe perhaps referral pathways with hospitals that are not doing Welcome Baby, but may have a way to work with some of our HFA and PAP providers to create referral pathways.
Thank you for all that information. Thank you again. Deanna, not Diana.
Romelis, were you had your hand up?
Yes, my question gets to be about referral rates from these different systems, because the presentation didn't highlight that DMH is a part of this system, in the sense that the referral rates from DMH and the referral rates from DPSS, are we tracking those referral rates? Because I'm hearing that DPSS is not making referrals like other systems are. Are we tracking that and trying to understand what the hesitation by these agencies in making these referrals for the benefit of these children? Question, that's number one.
I will start by saying, and I saw Dr. Allen go off mute as well. I think we are tracking referrals and where they are coming in. And I think it's not so much that entities, are not making referrals. It's about understanding the requirements or eligibility requirements to enter the program. So Dr. Allen, if you want to say anything about.
Yeah, I think DPSS, which is now our largest funder, is actually very committed to the program. I think, and we had a wonderful meeting today to which DPSS invited our providers to talk about what they felt were the challenges and barriers that DPSS could help them overcome in ensuring a wider enrollment of DPSS clients. So I think it's very much at the sort of implementation level that there are these real places the two systems don't match well. And a real effort is going on to try to correct that, which I think will leave room for expanded enrollment of DPSS clients. And yes, we're absolutely tracking the numbers. But I think the will is there. The procedures have to be worked out to really maximize that.
With regards to mental health, are they on board with that?
I don't know that DMH is a major referral source. They have been a funder. Their funding is ending.
We had to talk about that funding ending and things of that nature. So what are we doing about that with regards to engaging DMH to continue the funding for the benefit of these mothers that may have mental health requirements, the traumatic experiences that go on with COVID and other things that we're having. So them dropping out is a question mark in my head about the benefits to these children and families. And I do have a subsequent question with regards to Black families and how we're integrating their services in there that is culturally relevant to them. So they will engage home visitation. And are we going to track that and report that? Because I'm
absolutely
about it.
Yes,
So do you have
absolutely.
numbers?
Oh, sorry.
I'm sorry. Do we
No,
have
no,
numbers? on that?
absolutely. I mean, I think, DPH has gotten a grant from the state, which is now going to be continued. It looks like for 2 more years, to have,
Good.
to continue a doula program as a model of a sort of variant on home visiting, that has a very high acceptance rate and very high positive satisfaction from Black mothers. It's exclusively for Black birthing people. So that model is uniquely tailored to Black cultural, comfort and norms. In addition, I think one of the things that FFPSA offers us is, unlike the relatively structured and frankly often didactic models of care that are now available, FFPSA counts motivational interviewing, which is a much more client-driven approach, as one of its evidence-based models. And we're very excited about the opportunity to branch out into a more client-centered approach using FFPSA as our evidence-based practice. And that's one of the reasons you've heard so many times in this presentation about FFPSA as one of the positives for the future. And one of the things we're going to try hard to capture through our funding approach.
Can we elevate that? Because that was another question of mine, is client input and satisfaction. And are we tracking it, and are we getting a report on what the clients are saying about what we're doing and how it's helping them across these different spectrums?
We do definitely have, Commissioner Morales and Welcome Baby. There is a client survey that they complete that includes questions around satisfaction that we are tracking across time. And I know that for HFA and PAT, there are also opportunities to provide input to their advisory bodies that each agency has for their programs.
Okay, then with regards to the referral funding and the funding, because we highlight what the great work that you're already doing with Department of Public Health, but let's also capture and highlight the efforts of DPSS and DMH and the referral from DHS, because DHS has a lot of our client base and they should be making referrals. Period. Because if they don't, these children and these families don't get the help they need. So I want to know what DHS is doing about making referrals to home visitation. Can you help with that?
DHS is also implementing the Mama's Neighborhood program, which does have a component for home visiting. We do continue to track and engage across our system efforts to create more integrated and more smoother referral pathways. And I think definitely those conversations around sustainability are bringing county departments to the table in different ways and really highlighting how do we integrate our efforts and connect families to services.
I mean, I would say DHS is very much they are actively involved in the CLC. And they have their own Mama's Neighborhood program that does home visiting, but we also worked very closely with them 2 years ago to get a federal Healthy Start grant, which also includes home visiting as one of its elements. So we feel that those are sort of home visiting aligned. I mean, they don't fit the federal definition of home visiting because they're not exclusively home visiting programs, but they are essentially providing the service we want to see provided to their populations. So they are very much part of our system in that sense.
Morales, this is Dr. Hager. I remain very concerned about referrals from the Department of Health Services. All right. I think that, that is particularly, I'll just raise one issue because this is my one note that I always talk about, is when you do have kids born that are exposed to substances, we can't rule out that they have not already also been exposed to alcohol, which means they're going to have subsequent problems that are going to be significant and severe in their ability to be prepared to go to school. And we would recommend, if we had the opportunity across the board, is to train anybody who's doing home visitation so they know how to recognize kids that have FASD, and the children that are born to substance abusing are using mothers, that they end up getting followed in a appropriate clinic for a minimum of 2 years until you actually have a better opportunity of assessing all of that. And I think that becomes critically important as we become more aware of how to treat and recognize this and anticipate problems. And as you and I have discussed, this is particularly important in the African American population, where we have created an environment where there is a lot of isolation and a lot of alcohol use that probably we should be advocating for. And so that's one of the things that I would like to see that we do. The other thing that I think is really important in this whole issue of home visitation is that we know, and I think probably Deanne taught me this, was that when you have calls that are coming in, particularly about children under like the age of 3 or under 5, saying that I get reports that are not substantiated, that are allegedly from the hotline not substantiated, that 50% of those little kids end up in the system. And that maybe we should use that as an opportunity that somebody actually put their hand up and said, I'm over here and I need home visitation. I need somebody to come in my household. To me, one of the major impacts of home visitation is the breaking of the loneliness and the isolation. That is what breeds child abuse. And every study of effective programs that stop child abuse in the community basically move in on dealing with isolation. So I think that's critically important. So when you do get that call, that there's a response. Now, finally, I'm part of a greater group of troublemakers in the county who are looking at ways to anticipate problems with kids as they go into foster care, et cetera, et cetera. And there's not from me, because I have this argument with them, but from them looking at reports that are coming in to DCFS from mandated reporters and from teachers and health providers, et cetera. They would like to do away with the protocol that says if you get a report from a mandated reporter, you have to go out and do an assessment and see what kind of trouble the family's in, because so many of them are unsubstantiated. And again, that's the problem, is because here we have families that somebody's putting the hand up saying, wait, this family's in trouble. And those are the families that I think that would benefit profoundly from home visitation. So that is my personal message, is I think there are indicators that we aren't necessarily responding to that we need to. And I don't think health services is doing the job that they need to be doing for whatever reason. But I think we could take advantage of those first calls.
I want to jump in on that. I agree with Astrid. We need to second and encourage our colleagues in DHS to collaborate with us and integrate their data set with our data set so we can measure what they're doing and what they're not doing and how we can help them to succeed in helping these children and families. If we're not capturing these data across these different systems, then what we're doing is working in isolation, and we are doing our thing and they're doing their thing and nobody's talking to each other. So one of the strengths of what we've been doing as a group and as a team is that we work towards integration and collaboration, and we work towards improving the process across systems. And that's why I was concerned about us not talking more about DHS, but I also want to make sure that what we're doing and these systems, and the reason I'm more concerned about DMH walking away is that these people have been traumatized by systems that are detrimental to their well-being. And whether you realize it or not, it impacts how the children are treated, how the mother is treating that child, and what the child is feeling. And even the children feel that trauma. So I'm hoping that we elevate that in that aspect to make sure they're getting the well-being services that are needed from mental health that they need timely, along with the other things we provide under under home visitation. That's a very significant issue for these children and families. They don't even realize it. They're just living in it. And so we need to make sure that we're doing all we can to elevate that and treat that so that well-being is happening due to that trauma.
Yeah,
So-
I think too, Alice, in that vein is the kids that have been on, Deanne knows more about this than I do, but the kids that have suffered death at the hands of caretakers in the last couple of years, it's really, really clear that the family members are suffering from severe mental impairment. And
Thank you.
and that without having the idea of looking at their mental health, we weren't really looking at prevention in a very steady way. I wanted to compliment. I realize that I'm a commissioner, so I guess I'm complimenting myself. But First Five and everyone that presented today, I really want to say something about, in working in this field for as long as I have, to see this coordination of services and standardization and bringing and oversight, and so that everybody's playing on a field in a coordinated way is really a tribute to your success. And it's it's the reason why it works. If you let everybody just do their own thing, and we wouldn't have the level of success that we have. But I just think we should be doing more. And I'd like to train everybody that does home visitations to recognize fetal alcohol when it's there, because these kids are in trouble as they get older. And as somebody asked me to do last night, was asked me to go to San Quentin and do a study on those who are incarcerated and how many of them were born into families that where alcohol was omnipresent. So I do think that we could set a standard here, which would be amazing for the country. So I want to thank everyone. Are there any more questions or statements or any public comment?
We do have Charlene up next, and then Anna, and then we do have a public comment once board comments are completed.
Okay, all right. Thank you.
Thank you. I actually was going to take a step back to respond to Commissioner Taylor's question about the number of African-American Black babies that we have in the program. What I also wanted to talk about, actually, just before I answer that question, is the amount of work that's being put in to increase the workforce as related to African-American and Black workforce increasing. One of the things that the African-American Home Visiting Engagement Group did through the consortium this fiscal year, actually just a few months ago, with the help of the data work group, was previously we just did not have any data, baseline data to any of our knowledge that gave us a sense of what the staff diversity was in the home visiting world. So those programs that were funded by First Five and the county, plus others. So it didn't just include HFA, PAT, and Welcome Baby, but any model that was willing to give us information, including NFP and Early Head Start and so on and so forth. So we do have a staff diversity report on the consortium website that gives you a better sense of the breakdown of who exactly is our workforce and what they self-identify as. Interestingly enough, it very much matches with the family breakdown that we see. We just had our annual summit just at the beginning of the month, and thus far in the fiscal year, we did identify that the number of families that self-identified as African-American or Black was about 8-9%. And about 78% identify as Hispanic, Latinx. So we're seeing that there's work to be done, but we're also understanding that there's some of those foundational pieces that need to take place. We need to take time to discuss, ask the right questions so we can make the right move. I'm thinking about a few years back, and I know Melissa Franklin and Randy Sims were a big part of this as well when we were starting this work group, of the communication and marketing piece of all of this. We had families that came in, we talked to them, what gets you in through the door, they had really good feedback, and a lot of it came back to genuinity. Is like, I just need my home visit. My home visitor does not need to look like me. I just need to know that they're there for me, whether or not they have the answers. And that was incredibly powerful, because it told us that we can do this together. The other thing I'll say is the unique makeup of the African American Home Visiting Engagement Work Group includes sites with incredibly strong Black leadership in home visiting and the supports for families with young children. That work group is also unique in the sense that most of the members are direct service providers. They are the home visitors. They are not the managers or the supervisors. So what it's created is it's created a space for the home visitors themselves to come together and push the work forward as they see fit. Which I also think is a unique space there. But we continue to monitor. I think as we're starting to make some programmatic changes, whether it's in material, language, and things like that, it'll give us the opportunity to further look at outcomes broken down by race and ethnicity to see what the difference is.
Who's up next? Any other statements or questions? Help me here, Linda. What's
Anna, you're up next.
okay?
Thank you. Yes, I wanted to reflect on a comment that Commissioner Hager made and elevate a really exciting aspect of FFPSA implementation in California is that the state has chosen to include in its eligible populations, or what they refer to as candidacy subgroups, a set of children who are identified to have some level of risk, but who have not been referred to DCFS. And instead of being referred to DCFS, they remain in the community and are referred directly to programs like home visiting. So some examples of that are actually the substance affected infants through the Plans of Safe Care work group, adults with substance use, children exposed to domestic violence, homeless children, trafficked children. So these are children who have been identified to have some level of risk, but will be referred within the community without DCFS involvement. So it's a really exciting opportunity to think further upstream about prevention, and the FFPSA implementation groups are really thinking about how to create those referral pathways, one of which actually is through probation that will be tested out. So just wanted to elevate that.
Yeah, now can I jump in here, Anna? That's great. But you see now that you're talking about those different categories, the connection back to mental health and the well-being of that is key to their success in the future. So let's make sure that we're collaborating with DMH to elevate that and continue to get that funding, because intervention and creative funding under MHSA is there to do just that and address these kinds of issues. So I'm still trying to understand why DMH is walking away. And I just need to know so I can talk to whoever it is at the board level to stop that nonsense. Because the reality is these children need these resources and they need it badly, especially now, more than ever.
Deborah, you're up next.
I think we should all adopt your approach to this and really pursue that partnership more forcefully. I did want to say that there is a program that hasn't been mentioned very specifically within DHS about substance abuse, and that's that they have a contract with SAPC, the Substance Abuse Prevention and Control Division that's in DPH, to serve. They're providing education about reproductive health to all of the providers of substance abuse care, with the understanding, with a particular focus on the idea of substance abuse providers doing screening of women about pregnancy risk, pregnancy intent, in order to intervene prior to pregnancy around the impact of substance abuse on pregnancy outcome. So rather than wait for a baby to be born and intervene, they're going further upstream and intervening for women in the substance abuse. They're screening for pregnancy among women who are known substance abusers rather than screening for substance abuse among women who've just given birth. In addition, though, they are doing reverse referrals where within their prenatal care, they are identifying women with substance abuse issues and referring them for substance abuse treatment during the pregnancy. That's a approach that we'd like to see grow, including in mental health, of screening the women of reproductive age that are served by the mental health system about their pregnancy status, rather than waiting for the baby to be born and then trying to intervene around the mother's mental health needs. So I think it's important that people know that that effort is going on. That's not to say that there may not be lots more opportunities to work with DHS. And I think the idea of fetal alcohol training for our home visiting providers would be terrific. We do train them, we do some supplementary training around risk that Charlene is very involved with, around trauma prevention, trauma awareness around mental health, but I think that would be an appropriate addition, and around domestic violence. That would be a very appropriate addition.
What's
Thank
up?
you, commissioners and staff. If there aren't any other board comments, we can move on to our public comments.
May I just say one thing really quickly? I am really pleased that we keep coming back to the fetal alcohol syndrome issue, because fetal alcohol damage is far more toxic and fatal and damaging than, frankly, any of the other drugs. We're, of course, now dealing with fentanyl, which is deadly in a way that we've never seen before. The number of fentanyl deaths in children has exponentially risen. So we need to weave the whole issue of substance abuse and substance danger is so critical. And I also want to land on that issue of isolation. If I ever say one thing about home visiting that is absolutely true and positive, it is that it is breaking isolation, which is the #1 risk factor for harm. So I'm so pleased that we're investing so much in this incredibly important program, and expanding to reach a broader audience, including like our 64 hospitals in our network. They're not yet part of the program. There's over 1,000 newborns now being referred for high risk. So we're seeing the numbers validate the concern that we're addressing, that needs to keep up with the rising challenges that we have in protecting and serving children. So thank you.
Thank you, Commissioner Tilton. Deborah, did you have another comment before we moved on?
No,
Okay.
sorry.
Are there any public comments at all, Linda?
We do have one public comment from Nakia Fields, and we're going to go ahead and begin her public comment now.
Hi there. Thank you for having me. Thank you, First 5 LA Commissioner. Thank you to all of you for having such an important conversation. I did put my question in the Q&A and it was sort of addressed, but I really like what I'm hearing, especially the culturally inclusive components and understanding who's referring people to home visitation programs, and that home visitation is not a punitive thing, but a supportive thing. And it looks like mental health. It looks like wellness. But the question that I asked was, how are we tracking the organizations, especially Black-led organizations or providers that are actually contracted with the organizations that are being referred? Because what we're finding out here in the community is that even though there are home visitation programs that exist, we are not truly finding home visitation programs that have Black people that are coming out into our homes. And we do know that there is a prevalence of more Black people being, referred to DCFS when there's a fetal alcohol or exposure to cannabis at birth. But we don't have people who are there being the welcoming arms once that exposure has been identified. And I think that's a workforce development issue. And so I would love us to continue to have this conversation and really do talk about how are we going to develop the home visitation workforce for the Black community, more Black providers as the faces, because we are more impacted by the microaggressions, micro insults that people don't realize that they have when they come into our homes because our culture is different than yours. Thank you.
Thank you, Ms. Fields.
Any other comments?
We don't have any other public comments.
So are we moving on to item 4? Is that what where we are?
Yes,
And are we going to take a break at this point for how long?
Yes, we're going to take a break right now.
So can we come back in 10 minutes?
That works.
Okay, so that'd be like at about 2, what is it? Yeah, in about
Turn
2:40.
at 2:46.
Yeah. All right. Thank you, everyone.
Thank you.
Linda, what would I do without you? I would just fall on my sword.
I'm sure you would do great without me, but I'm here to support you in any
I
way that
appreciate that.
I can.
I do appreciate that. Anyway, so we are coming back in another couple of minutes here, right? Or now?
We can begin now. We're at 2:46. I believe commissioners and staff are getting back.
Little things like this.
I just think that this item 5 should be called the Beyonce Initiative, and we should just, as I move in the direction of trying to get that kind of, it'll never happen. I mean, kind of try to organize. It's like herding cats here from time to time. But anyway, we shall see.
And I think we can ask Nicole Jones to begin.
All right, can we all basically say we're back on? I can't tell who's all on back, but I'm assuming everybody's back. And we're going to talk on Nicole Jones is going to talk about, I'm really interested in the African American. This was the very first thing that happened when I became a commissioner, was this conversation about mortality of infant and mother mortality in the African American population. And there's a huge concern of mine that we aren't doing a better job. So Nicole's going to start on item 5, and we'll go there. Thank you.
Hi, good afternoon, commissioners and First 5 LA staff. Can you all hear me all right?
We can.
Okay, great. So let me go ahead and all right, so good evening, everyone, commissioners, First 5 LA staff. We welcome you today. My name is Nikki Jones, and I'm a program officer on the health systems team. And today we are going to be presenting on our AIM initiative. And we're going to be sharing some of the ways that we have been grounding our work in community wisdom. Today, I am joined by our partners, Dr. Deborah Allen, who is the Deputy Director for Health Promotion at the Department of Public Health, as well as Adjoa Jones, who is a Director of AIM Outreach and Engagement Prevention Initiative at the Department of Public Health. So here's our presentation outline. We will be giving a brief AIM overview. We also will be sharing some highlights from our community action teams, also known as CAPS. And we will be talking about next steps and opening up the room for discussion. So as you all know, the AIM initiative is near and dear to many of us here in the room. It was founded in 2018 by LA County Department of Public Health. First 5 LA, community-based organizations, funders, community members, all united to address the unacceptably high Black infant and maternal mortality rates, and to ensure that we provide healthy and joyous births for Black families here in LA. And as you can see, it takes a village to do this work. So I'm very grateful for our partners at DPH and at the community level. We are guided by our shared values, which both direct our collaborative efforts as well as our investments in programming. These values were co-constructed in partnership with members of our steering committee, and which is inclusive of our county and community leaders, as well as our funders and other partners. And so at this time, I would like to introduce our partner and colleague, Dr. Allen, Deputy Director of Health Promotion Bureau, to shed a little bit more light on the AIM initiative. Dr. Allen, you're on mute.
Sorry, thanks so much, Nikki. As you'll see when we present the data, there's a crisis of inequality in birth outcomes. It is, however, not an acute crisis, but a chronic one. It's a reflection of the lifetime experiences of stress felt by Black birthing persons in LA and California and around the country. The effects of racist laws, of policies, institutions, of interactions with individuals and with systems, and the failure of systems to address community needs come together as sources of stress affecting Black birthing persons. I'm going to paraphrase the title of a popular book on trauma. Really, the Black pregnant body tells the score, keeps the score. That's what we're seeing when we see these elevated rates, uniquely elevated rates of infant and strikingly elevated rates of maternal mortality, is the impact of cumulative sources of stress on Black birthing persons. Next slide. The understanding that social conditions and social experience lie at the heart of birth outcome inequality shapes the framework that guides AIM work. That framework starts upstream by asking, okay, if the sources of the problem lie in social experience, what can we do to change the social environment? Specifically, what can we do to reduce the sources of stress that affect Black birthing people? At a midstream level, we ask, what can we do to assure that the social stresses in the environment don't convert into physiological stress that places the Black body at risk of adverse birth outcomes? And at the downstream level, we ask, how can we advance a healthcare system that remediates the impact of stress on Black infant and maternal health? And throughout this continuum, this cascade from social experience to biological outcome, we've asked, what kind of infrastructure do we need to effectively respond to racism at every level? Thanks so much.
Thank you, Dr. Allen. So here you'll see our AIM collaborative structure. It's in the form of a lovely flower with our AIM steering committee at the center, but grounded and surrounded by our community action teams, of which there are 4: San Gabriel Valley, South LA, South Bay, Santa Clarita, San Fernando Valley, and the Antelope Valley. We also are supported by our Cherished Futures Collaborative, as well as our Doula Advisory Committee. And in order to do this work, we have an approach that we like to call a collaborative of collaboratives. And we use this approach in solidarity to work and lock arm with one another to ensure that our Black families are having safe and joyous births. We also uphold shared power in decision-making, and we ensure that all of our engagement is driven by the community partnerships that we have cultivated, as well as grounded in that community wisdom. So we'd like to share with you all some critical milestones this past year for AIM. And we're happy to share that we have, at this point, contracted the UCLA Center for Health Policy to conduct evaluation for the AIM initiative. And the evaluation questions that we have our team focusing on are divided into those that assess the overall and high-level impact of the initiative. For example, one of the questions are, did AIM implementation lead to the desired outcomes at the community, provider, and individual levels? Such as, did it reduce Black infant mortality and stress among Black birthing persons? And so, like many things due to COVID, there have been some slight delays with initiation, but we are on track to complete evaluation June 30th, 2022. And so at this point, UCLA is working very closely with AIM management and steering to gather detailed information on the various programmatic components of AIM and activities. They are examining the content of this data and assessing the feasibility of collecting additional information in order to address any gaps. And so they're looking at all available sources of data, including reports, training evaluations, meeting agendas, scopes of work, and et cetera. I'd also like to take this time to highlight some programmatic accomplishments of AIM. Of course, we shout out our lovely Dr. Melissa Franklin, who leads our communications and public awareness efforts. We've created an amazing website that serves as a landing place for external, both internally and externally. And it really keeps that place of robust information sharing, as well as we have our social media channels, core messaging, and overall broad reaching campaigns. We also have Cherish Futures, our hospital quality improvement program, which has supported 8 hospital teams to co-create implementation plans with community members to improve birth outcomes for Black families through coaching, analysis of disaggregated data, listening sessions with Black families and providers, and overall just fostering a community of learning and best practice. We also have our Black Maternal Health Center for Excellence, which is housed at Charles Drew University and will launch in July. And lastly, but not least, we also have our doula program, which is was mentioned in the earlier presentation, an evidence-based intervention that provides critical social emotional support for Black birthing people. And up to this date has made 879 referrals and helped deliver over 399 babies. So at this time, I would like to pass the baton over to our colleague, Ajwa Jones, Director of AIM Engagement, leader and visionary of community action teams.
Thank you very much, Nikki and Dr. Allen. Good afternoon, First Five commissioners, colleagues, partners, community partners, and guests. I want to thank you for allowing us to be here to present. Gratefully and thankfully, the AIMCAT model came to me as a vision, which arose out of the work that I had been doing since the early 90s, as I was the first community health worker and perinatal health educator for the first Black infant health program in LA County, which was Great Beginnings for Black Babies and the Inglewood Healthy Mothers and Babies. And so the AIMCAT was, at that time, I was with DHS Whole Person Care. And part of our work was to identify gaps in services and resources and look at ways where we can either create a community action team or join one that was in place. And there was not one at the time in place. And so what we decided to do in conversations we were having with DPH and DMH with the health agency, as well as First Five, was I came up with the idea from my regional collaboration team to lead that work in developing an African-American infant and maternal mortality community action team, which was a partnership between government and community to address and look at ways that we could intervene and create strategies and support the current organizations that were providing services, especially at the grassroots level, some of the smaller CBOs and nonprofit organizations. But then also to look at doulas, midwives, birth workers of all types, and the African-American community, as well as faith-based partners, to see how we could further introduce this issue and then also see if there was a need, if the community felt there was a need. And at that first meeting and in talking with Kaiser and them being a partner in serving as providing us the space and providing the food to be able to share with those, to make it a welcome environment. We had over 100 folks there, and the community said, yes, we want this model. And it's to be a model that is co-led by community and government. So for example, at our planning team level, I am leading South LA, South Bay. We're going to be looking for a community leader, as well as within some of the other CATs, there are some community co-leads. But then at the work group level, each work group is either led by a community member and a county member, or it can be led by 2 community members. But the whole purpose is to really look at where are we at with this issue of AIM? Does our community know about it? How do we further engage community members such as fathers, such as birthing persons, women and birthing persons? And how do we support them and really activate our village and support pregnancy and birthing for Black people without bias and racism? And so we first started in South LA, South Bay in October of 2018, officially launched in January of 2019. And then Antelope Valley came in 2019, and San Gabriel Valley and SPA 2, Santa Clarita, San Fernando Valley came 2020 and officially, well, 2021 and officially some in 2022. But the bottom line is it has been replicated in 3 other areas throughout our county, and we're finding to have great success with the work that we're doing. Next slide, Nikki. Some of our highlights today is the first, we were able to, with fatherhood, I was able to bring a gentleman, Henry Solomon, into our work with the South LA South Bay planning team to talk about how do we further engage our fathers. And one of the first things he did, along with some of the members of the Family Centered Models of Care work group, was to implement the Black Daddy Dialogue, which started in 2019. And when COVID happened, we pivoted to offer that virtually. We were initially meeting in person at the MLK Center for Public Health. And that group meets every second Wednesday of the month. Then also San Gabriel Valley and their AIMCAT, they are focused on maternal mental health. And so you heard from co-lead Nakia Fields when she asked her question earlier, but through her team and her leadership, along with Annette and Trejo and Chalet Lewis of the county department, they have implemented 2 support groups that are being offered right now to virtually, but will be also implemented in other places throughout our county. But San Gabriel Valley has led that work. In each CAT meeting, we offer racial grounding for our bi-monthly meeting so that we give a historical perspective on what the experience has been for African Americans in this nation for the last 400 years, as well as within our community. We also offer partner spotlights because many do not know some of the agencies that are serving them in the community. For example, if you look at the picture here, this young lady offers 4D ultrasound, and she came to 2 of our events of late and is willing to still serve and was offering free 4D ultrasound. So imagine the women came and were finding out, at some of them that were pregnant and parenting and birthing persons, and was like, oh, I can have a free ultrasound. And so that's some of the work that we've been doing. We're also going to be having an AV birth worker where we're looking at the Black birth worker capacity in Antelope Valley and looking at how we can strengthen that. So we have a consultant that is able to work with us to develop the pretty much a needs assessment and an analysis. And then we will also work with those in AV so we can build that out. But I will say that you saw what we call, Nikki called the flower. We really are now calling it a garden because it keeps growing and growing. But much of what has happened within the AIM structures first began with the AIMCAT, especially in South LA, South Bay. Cherished Futures for Black Babies, the hospital collaborative, as Nikki and Dr. Allen mentioned, is led by Dana Sherrard, who was one of the first to come to one of our meetings, as well as the CDU, Center for Black Maternal Health Excellence, led by Dr. Bita Amani and Dr. Brandy Desjolais. First also started within the AIMCAT meetings, the planning teams, and the actual bi-monthly meetings to our community. And so we're also happy to be partnering with I Dream for Racial Health Equity on their Black Mamas Glowing prenatal support group. AVCAT started a village support group for Black pregnant women. We also have, thankfully, to Casey Patterson, the AIM Village Fund, and fatherhood engagement really sprang forth even more because our South LA and AV AIMCATs were able to participate in the PEI grant application that the county submitted to give thought and ideas to what interventions we thought would best serve the African American community. Next slide. So just to bring you a little up to speed, we're very excited about a couple weeks ago, we had a Father's Day Juneteenth celebration where we wanted to really honor the fathers. For Black Maternal Health Week, we focused a lot on Black women and birthing persons and focused on their needs, but we also wanted to uplift the father. So we were very excited, as you see in some of these pictures. These were some of the gifts that were able to be given to participants. We also have fathers there present with their children, receiving free haircuts for them and their children. And then we have designed a special shirt that says Support, Protect, Believe Black Women that our team is now wearing. And for August, you'll see last year at the bottom, we participated in Black Breastfeeding Week, and we did a walk throughout Leimert Park in our South LA community, and we'll be hosting that event again. So we're very excited about the work that has begun, and it continues to grow within our African American infant and maternal mortality community action teams known as the AIMCATs. Thank you very much.
Thank you so
I'll pass
much.
it back to Nikki. You're welcome.
Thank you, Adjoa. So as you all can see, all of the great work of our CATs to date would not have been possible without a high level of community involvement, as well as community-based backbone support. And so what is backbone support? So we define that as referring to it investing in a community-based organization or individual to coordinate this CAT work. It provides seed funding for CATs to develop core infrastructure and quote unquote, get their legs under them. It is not programmatic support, but overarching structural support. And to date, 2 community action teams have had some backbone support and 2 have had none. So responsibilities include providing administrative, operational, and logistical support to community action teams, supporting organizational infrastructure building, such as fundraising and evaluation, and overall working with CATs to implement their goals. And so this is critical because of 2 reasons. One, it helps shift the balance of power back to community. As Adjoa mentioned, CATs are currently intended to be co-led by DPH and community. And so investing in community backbone helps shift the balance of power more fully back to community. Furthermore, community organizations co-lead in CATs on a voluntary basis with little to no financial support, which can contribute to burnout. So additional funding can help further support our partners with the additional administrative and infrastructural support they need. So the item that we are bringing you today to the board is really to seek to respond to these learnings of AIM leadership by promoting CAT's growth and sustainability through investment in backbone support. So our partner in funding community-based AIM efforts like CAT's is through the LA Partnership for Early Childhood Investment, also known as the LA Partnership. First 5 LA first established a strategic partnership with LA Partnership in June 2020 and has been in effect for 3 years. This fund contributes to the AIM Innovation Fund, which is a pooled fund which leverages public and private funding to support AIM sustainability and community-driven strategies. And the purpose of this fund is to support 2 main areas of work. That would be community grant making for the Village Fund. And these funds are community-based organizations or individuals to help implement and evaluate local strategies to support the well-being of Black families before, during, and after birth. And these grants are not tied to any particular region, but are open to any eligible applicant throughout LA County. And for the second reason, to support with advocacy and capacity building for our community action teams. And so to name a few achievements to date, and for the sake of time, I'll just highlight a few. Firstly, our LA Partnership has successfully launched 2 village cohorts comprising of a total of 15 grantee organizations and individuals rooted in Black communities across LA County. So by the end of 2021, we served in our first cohort of grantees a total of 768 families. Furthermore, due to the capacity building efforts, we brought on consultants to support with infrastructure building and fundraising for our community action teams. So the item we're bringing forward today, seeking to expand the AIM Innovation Fund, current capacity building efforts for the CATs, and really to continue and invest in the backbone support for our community action teams. Therefore, we are requesting to amend the current strategic partnership for an additional $400,000 for our community action teams, backbone support, and additional capacity building efforts. So this will bring the total investment for AIM Innovation Fund to $700,000. This funding will ensure that each community action team has a minimum of $100,000 for CAT serving 1 DPH service planning area, also known as SPA, and $150,000 for those serving 2 SPAs. These amounts were based on the learnings from existing backbone support to date. So next steps include returning to the board in July to approve a strategic partnership amendment to include CAT's backbone support. And Other items and priorities for AIM in the coming year include strategic planning, in which we brought on a consultant for AIM steering and community action teams to revise our structure and help us finalize our strategic plans for fiscal year 22-23. We also have 2 Pritzker Fellows joining us to help support with data collection and relationship building to explore systems integration between AIM, home visiting, and Help Me Grow. We've already met twice, and we focused on learning, centering equity, and relationship building. And so with that, I'll conclude our presentation. Thank you so much for your attention. And at this point, we'll open it up for questions.
Do we have any questions? Here we are.
I see Commissioner Taylor, you're up.
Okay, there we go. First of all, let me thank you for the great work you're doing in the community. Like the other group, you guys are doing good work. The only thing of my concern is getting data out that says, and I can't wait till I get the report. So I would like to make sure that you come back to the commission and report on the outcomes of that report, especially are we making an impact in reducing the number of Black women and children that are dying in our community. And by the work you're doing, it should be better. The other thing is what I would like you to highlight more, and I don't know it really came forward, is that a lot of this expansion fund is about giving them the ability to do sustainability work, right? And so let's elevate that, because it's not just about doing the same work. It's about teaching them how to go out and get funding to do that work. I read it in your memo, but I didn't hear it in your presentation as much as I would have liked to. Good work. I just want to thank you for your work. And hopefully you can tell us just in an anecdotal piece how the communities and families are feeling about what we're doing. Just one story. I believe in stories, by the way. So who's going to talk to me?
I will talk to you.
Okay.
I mean, the whole story piece, it really goes back to what I've been doing for so long. When people see me, they always want to know, are you still helping Black mothers and babies? Are you still doing that same work? So we are getting more and more that are interested. As I even wore the shirt, it has become my whole new uniform. I met a pregnant woman on Monday when we were off, who was headed in for induction. And I asked her, do you have a doula? And she said she was having twins. I'm like, I can see you're ready to deliver. And she's like, no, I don't, but I'd be interested. And so we exchanged information. I sat there with another family who they were across from us, and I was listening, kind of a little ear hustle. And I was hearing the husband speak, and we just turned around. I was with a social worker and a nurse friend of mine, and we turned around and we just started talking to them. Come to find out, they had newly had their baby who was in the NICU and had a heart surgery, African-American couple, and they were in need of support. So they were very interested. And I told them about our Black Daddy Dialogue and Jessica Wade, who is of Mighty Little Giants, who created her NICU program. So this is just smaller stories, but we have a story every day. We have partners joining our work every day who are very much interested. We're having more conversations. I had one with DCFS earlier today, who is interested in learning how they too can partner more. And I told them about the consortium and the African-American home visitation. So our sustainability is much needed, because we knew we would not solve this within 5 years. What has happened for over 400 years can't be fixed that easily and that quickly. I hope I answered your question.
You did. That was a good story. One other thing, you can, I hope you will share, I know Dr. Allen had already talked about it, is the impact of the mental health portion of this that you're doing, because the trauma of the systems that affect the Black people, people don't translate that into mental health and well-being, but it is there. So how is that going? And are we connecting with Department of Mental Health to get the trauma issue addressed properly?
DMH has been a partner with us since inception. So we do have some DMH staff that are part of it. I'm sure you know Keisha Thompson and Dr. Erica Melbourne. They're part of our work as well. And so we are making further connections. I will also tell you that I have some professors that have reached out that have BSW students that they want to partner in the work. And so we're looking at ways that we can further expand mental health services and support. I'm even being told that USC does some offering of mental health services. So what we're doing is looking at ways that we can further partner and engage and offer people the services and let them know that they're, this is a way we're not trying to increase harm, and Black folks have to feel comfortable. We all know that because, it has been just what has happened systemically that we have more Black children being removed. So folks are fearful of what to share. And that is why I approached the gentleman and his wife, because I wanted to make sure they were offered the mental health support they need, with a new baby that had various health issues as well as the other children they have.
Thank you for your work.
Thank you.
We'll leave it to other people that have questions. Thank you.
Thank you, Joe and Commissioner Taylor. Up next is Dr. Allen and then Commissioner Segala.
You're on mute.
I was saying I'll go after the question.
Okay, I wanted to commend you all for the wonderful work you've been doing, and especially we need the data for Black fathers. So we know very little about it, only that 400 years of oppression has had to have had a profound effect on males, and we don't have enough data on that. So I'm sure that as a result of your work, you can give us some rich information so that we can educate ourselves about what we need to do systemically to change the situation and to become more enlightened. So I look forward to the information on that, on your outcomes in that area, and I hope that you can provide us with that.
If I may go now, I'd like to comment on mental health, if I may, and really to tie it to our framework. So at the very broadest level, thinking about social conditions and social experience, a very important part of what AIM does that I see as a mental health intervention in a population scale is to communicate that when there is a loss of an infant in a Black community to a Black family, that's the result of social circumstances, because one of the things that happens to families and is obviously a cause of tremendous mental distress is self-blame. And that happens in any family where there's a loss of an infant, where there's an adverse outcome, and really communicating that this is something, yes, it is something to grieve, but it also is grounds for anger. Just as we get angry when a gun kills a child, we need to get angry when social circumstances lead to an infant death. And that has a therapeutic effect, we think, of mobilizing people, giving people agency, giving people a place to come to get involved. Then on our second level, where we say, what do we do about supporting people who are subject to stress? Almost all of AIM's interventions have a major mental health component through person-to-person support. So the whole point of father engagement is support for the pregnant person and for the father's sense of agency in supporting the pregnancy. The point of the doula person is to relieve the stress experienced by the mother. The point of our birthing center that we're working on with Charles Drew University is to provide comprehensive integrated care that includes mental health and group prenatal care as a means of having Black women support one another. And then, finally, at the highest level, we're, engaged in dealing with problems that have resulted in people's health because of exposure to racism, really thinking about how we integrate mental health into all of healthcare services and build a trauma-informed approach in all of the hospitals. That's really something Cherished Futures has focused on. So the mental health is, in many ways, AIM is intimately tied to the notion of mental health because stress is really the link between social experience and these adverse outcomes. So I on the one hand, yes, we absolutely want to focus on mental health services explicitly, but we also want to reframe our way of thinking about mental health just as a clinician meeting a patient in a room and more as a trauma-informed county.
Thank you. Excellent.
Are there any more comments?
I don't see any other commissioner hands up.
Deborah, you just have your hand up. You're
Oh,
waiting for us.
I keep trying to put it down and ending up clicking one too many times.
All right. Are we ready to go on to item 6? I would like to just make one comment. I think I love what you're doing and I love this report, and I really would like to see an incredible investment in this part of LA County to begin to pull up social barriers and the pressure off of the African-American families, which I personally think is one of the major causes of the health disparities, and really invest in sending the best clinicians, Deborah, down there, not those who are willing to go, but those who want to go and want to make a difference and want to make an impact. And the more African-American top-notch doctors and professionals we can get down there in the clinics, the better. We not only in terms of service delivery, but also in modeling for the community and giving those kids an idea of everything that's possible for them in a world where they haven't always seen that. And maybe, I shouldn't say that, but I mean, to me, that's what I saw going through medical school and training and everything was this tremendous search for quality to send down there when we had inequities, not, we're unbelievable. And I don't know that we've made all that. We've made some progress, but we need to make more. So anyway, thanks for that report. And I'm looking at item 6, unless there's other comments, and looking at from Gina, I believe is going to report on the strategic partnership with Child Care Alliance of Los Angeles and et cetera.
And before we move on to items.
Astrid, can I just say thank you,
Sure.
Dr. Allen, for your great effort and work and leadership. Really appreciate that. Thank you very much, Dr. Allen.
Yes.
Okay.
Thank you.
That's it.
Thank you. And before we move on to item 6, confirming for the record that there are no public comments on item 5, and we'll move on to item 6, which is a written only item.
Written. God, what do I do with that? When it's a written only item, do we vote on this?
If there aren't any questions or comments from board members, we can move on to the next item, which is public comments. And this item will be up for action at next month's consent agenda item.
All right. Well, if there's no comments on this, then I guess we can move on for public comments. And it looks to me like that's coming to the end of our meeting, right? Am I right?
Yeah.
About that? Yeah.
And it does look like we do have one general public comment from Ms. Sonia Young Adam. And with that, I will hand this over to Ms. Adam for her public comment.
Hello, hi, thank you so much. I didn't recognize that I would have the opportunity to state it to you all directly. I appreciate the work of this commission. I'm Sonia Young Adam with California Black Women's Health Project, and the AIM team, Dr. Allen and Ajwa, have just really done the most amazing presentation of what AIM is and has the potential to be with additional support and resources. And my comment was really in response to the question, I don't know if it was a question or a request from Commissioner, I don't want to say, people pronounce my name incorrectly all the time, but the commissioner, so I'll be careful, but the commissioner who mentioned the need for more data on Black fathers, and that data would seem to be necessary to begin to think of ways to provide support or to intervene or resources for Black fathers. And so often we hear, these extensive requests, not necessarily extensive, as she didn't say extensive, but we hear requests for data so frequently, that I always wonder, like, data? I mean, what, like, how much more data? Like the very outcomes of, the lives of Black families and Black men, Black fathers, Black communities is so evident everywhere across every single social sector and institution that we can find, that it just it just makes me question, that there might be the need for more data in order to consider an investment or, some sort of a dedicated intervention. I mean, the AIM initiative is so incredibly unique because, most of you would already know in California, we are not allowed by law to use race specifically, as a criteria for, providing public investment. And here, because of the governor and the legislature, that's possible. So I just like to ask for the consideration that when we're asking for data, that we think very carefully about the data that already exists, that is readily out there, readily available, and can be probably compiled, in a very short space of time. So thank you.
Thank you. I think unless there's further public comment, I believe that is everything today, isn't it? Did I miss something here?
We don't have any other public comments.
So we can actually adjourn.
We
We're
can,
already
if there are no objections.
3 minutes early. Thank you very, very much. Always lovely to see you, Romales. Always appreciate your comments. Thank you for that. And let's all hope that we've learned enough that we can actually bring some change into our world. I'm really impressed with I'm learning more and more and more about this commission, and I feel very, very honored to be part of it. So thank you all and stay well.
Good job, Astrid.
Talk to you later.
Bye.
Bye, everyone.
Thank you, commissioners.
Bye, everyone. Thank you all.
Alice.
Bye. Thank you.
Bye.